Okay, we're going to switch, then you'll come back with the questions. Why don't... I'm going to ask, just because it's late and some people are expressing that maybe all of our colleagues just maybe do 2 questions, and the rest you can, like we said over 3 days, just memorize everything. You don't need to memorize so many things. It will be okay.
If I can have my slides pull up, please. Okay. So we'll just do 2 questions. This is a 69-year-old patient with a history of aortic valve replacement with a bioprosthetic 23mm valve, presented with shortness of breath, fatigue, never really felt better after his surgery. His body surface area is 2.2 and his height is 6'2". And you can see here, this is his Doppler waveform. You clearly see his velocities are close to 4 meters per second, but it does have the triangular jet. So these are his parameters. His aortic velocity is 4.1. His mean gradient is 36. His Doppler velocity index is 0.25. He's got a triangular contour, valve area of 1, body surface area 2.2, and acceleration time 74. So which does the person have? Does he have severe prosthetic valve stenosis? Does he have a benign condition? Does he have a high flow state? Or does he have severe patient prosthesis mismatch? Perfect. So the answer is indeed he has severe patient prosthesis mismatch. And if you take the aortic valve area and divide it by his BSA, you get a estimated indexed effective orifice area. So let's go back and look at that answer. You can clearly see that despite the elevated velocity, he did have a triangular contour and his acceleration time was shortened, and his Doppler velocity index was in that gray zone. And if we go back to our diagram and our flow chart, you see with a Doppler velocity index of 0.25, short acceleration time, you then deduct the indexed effective orifice area and you kind of go down the route of a patient prosthesis mismatch. And because this fits the severe patient prosthesis mismatch, then this is not a benign condition. This is the TE of the patient. You can clearly see he's got normally functioning aortic valve leaflets. Same thing you see on a CTA, wide opening of the valve. And then also on the MRI, you can clearly see that there's nothing wrong with the valve. This is the valve before surgery. This is what he had before the surgical valve at 23. He went for redo surgery, and they were able to expand the sinutubular junction and place a 25mm valve. And you can clearly see there's complete resolution of his gradient. Last question. Patient prosthesis mismatch occurs, which is the correct answer, occurs only with TAVR. Patient prosthesis mismatch occurs only with SAVR. The mean gradient is essential in the diagnosis of patient prosthesis mismatch, or acceleration time, ratio of AT, ET, and index effective orifice area help with identifying patient prosthesis mismatch. Perfect. Perfect. There's somebody there yellow who probably just pressed the wrong button. But so as we mentioned, that with prosthetic valve, we do not just count on the mean gradient, but we look at the accumulation of acceleration time divided by ejection time and the index effective orifice area to help us identify the patient prosthesis mismatch. It's been certainly a pleasure. It's nice to see you guys even after 7 p.m. and you guys are still hanging in there, so I think you guys are going to do just wonderful with the boards, and good luck. Thank you very much.
Vera, let's just stick with 2 questions each.
I don't know what it is. Before I was the holdup between you and lunch. Now I'm the holdup between you and dinner. I don't know. All right. I'm going to skip to this. Okay. So I'm going to skip ahead to this question. All right. This is a 28-year-old male with shortness of breath. I want you to carefully look at all the images. I'll give you 30 seconds to do so. Okay, so it's really question number one for you. What is the precise cause of the abnormal leaflets? Is it A, degenerative changes, B, a bicuspid valve, subaortic membrane, or prior endocarditis? Okay, so most of you got it right. It is a subaortic membrane, and I'll show you the membrane right here. Okay, and you can also get an idea of that because there's a very high velocity across the aortic valve. The aortic valve leaflets are opening beautifully, so this is not due to valvular aortic stenosis, but it's due to this subvalvular membrane. And then pay attention to this aortic regurgitation here because your next question is going to be about that. All right, so aortic regurgitation is commonly seen in patients with subaortic stenosis. The membrane's elastic tissue can encroach on the valve, cause fibrosis, and restrict motion of the cusps. In addition, the high velocity jet of the blood flowing through the stenotic membrane can traumatize the aortic valve, which then becomes fibrotic, which then contributes to the regurgitation. All right, so the next question pertains to the aortic insufficiency. I'm giving you the numbers and the images and I want you to calculate the ERO here. So the radius is 0.7, the aliasing velocity is 34, the VTI of the CW of the AI is 158, and the peak velocity is 391. So the questions are calculate the ERO and the regurgitant volume, and here are the choices that you have. So I'll give you a minute to calculate. I'll go back here so you have the numbers in front of you.
Whoever gets it right at this time of the day, you get a discount.
You get an automatic pass of the exam. All right, can I see the... Oh.
Drastic reduction in the number of people voting.
All right, in the sake of time, let's go over what the correct answer is. So the correct answer is an ERO of 0.27 and a regurgitant volume of 42. So again, here are the different elements of what you need to do the calculation. And the ERO is 2 pi r squared times the aliasing velocity divided by the peak velocity. And if we put that all together, it's 0.27. And the regurgitant volume is the ERO multiplied by the VTI of the AI jet, which is 42 mLs. So with that, and then just real quick, based on this PISA calculation, how severe is the AR? Can I see the votes, please? So here's our numbers again. Okay, so if we look here, the ERO of 0.27 and a regurgitant volume of 42 come up with a severity that's moderate in severity. So moderate is the correct answer. So with that, I will stop. Thank you.
Thank you. Excellent.
Okay. All right, very good. We'll pick two cases with images. Hopefully these will transmit on the recorded info. Okay, you have a 55-year-old man with a history of hypertension, hyperlipidemia, and diabetes. He's complaining of increasing chest pain over the 2 months. He's referred for stress echocardiography. He's exercised on the treadmill using the standard Bruce protocol, terminated at 6 minutes. Here's his baseline EKG with heart rate of 90, slightly hypertensive. At 3 minutes, he's complaining of some mild chest pain, and blood pressure is significantly more elevated. And then at 6 minutes, he finally convinces the fellow that it's time to let him stop because of his crushing chest pain. He has reached target, but oops, his blood pressure seems lower. And those are the EKGs. And here are the images. There is parasternal long axis, and you should scrutinize these. Parasternal short axis. Again, rest, post-exercise, recovery. This is the 4-chamber view. And finally, the apical 2-chamber view. So, do you feel you've had enough time to scrutinize the wall motion? I know it's tough because they're small and, anyhow. So, yep, ponder, contemplate, regard. Yeah, I'm trying to shake it up. I was looking for synonyms before. What does this stress echo demonstrate? Is it a normal EKG and echo response? Is it a false positive EKG with a normal exercise echo? Do the ECG and echo suggest anterior and septal ischemia, inferolateral ischemia, or isolated apical ischemia? Very good. That's actually not a bad response for everybody here. Very good. That is correct. Anterior and distal septal ischemia. A pretty large wall motion abnormality with his severe angina. So based on that decision that you've made correctly, what is the coronary artery status? Does he have normal coronaries? A 70% distal stenosis of the LAD, a proximal 50% stenosis of OM1, a total occlusion of the mid-LAD, or a total occlusion of the RCA with poor collaterals. We should reveal the thoughts. Yes, very good. The wall motion abnormality, particularly in the apical 2-chamber view, begins reasonably proximally in the anterior wall. So a 70% distal lesion could account for his apical wall motion abnormality, but things are starting to happen a little bit more proximally to that. And indeed, on catheterization, we can see that he lacks an LAD. He also seems to lack an RCA, a circumflex, but he is a very right dominant, and you can see the LAD ghosting in there with some collaterals. Very good, excellent work. Okay, this is a reasonable one. 52-year-old female smoker. She's 6 months post-bariatric surgery with a 40-pound weight loss, but she remains somewhat obese at 37 BMI. She's developed some new substernal chest pain, usually with exertion. Occasionally she feels it at rest, and a stress echo is performed. Her resting ECG is delineated here, and here is her exceedingly helpful peak stress echo after 9 minutes on the Bruce protocol with a normal blood pressure response. She did develop some mild chest pain and moderate shortness of breath. And that's why she terminated, because she felt very short of breath. Okay, those are the EKGs, and here is the echo. So I've put it in a little bit different format just because this is the way it worked. Here's the rest, post-stress and recovery of the parasternal long axis, the parasternal short axis. So you can discern what you can from those. And now the apical 4 chamber is on the top. Sorry, I get too close to the mic, I assume. And here is the apical 2 chamber on the bottom. Okay. So you make the following interpretation. Normal stress echo, no ischemia. Abnormal stress echo with inducible inferior ischemia. Abnormal stress echo with ischemia during the recovery phase. Abnormal stress echo with transient ischemic dilatation. Uninterpretable because the EKG was inadequate. I think we can reveal the results. Most excellent. Actually, yes, the correct answer is normal stress echo, but I will tell you that the person who read this stress echo read it as RCA ischemia because, we can move on with this. This is obvious. Hold on, sorry. So, I mean, the appropriate next step in management, we don't have to worry about that because you've already decided it's a normal stress echo, and y'all are correct. The reason why my colleague was, as we used to say at Penn, misled, was that in the recovery phase, they saw this sort of bulging outward of the inferior wall here. And they thought they saw it in both they thought it got worse in the exercise, interestingly enough. And this is a pseudo-dyskinesis pattern of some sort of elevated subdiaphragmatic pressure. So the cavity becomes rounder during systole. So you guys, even in your incapacitated, exhausted state, still did well. So that is excellent. Okay. And we will stop it there because the other questions you can see in the thing. Again, thanks again to both Vera and Roberto for once again having me back. It's a real pleasure to be here. It's a labor of love, I think, for all of us. We really do enjoy working with you guys, and I hope you all do really, really well on the exam.
Okay, 2 questions for 5 minutes.
Okay, so might be even less. Okay, so here I'm gonna do okay. Where is the okay? So we'll start with this question. So 28-year-old woman comes to follow up a transthoracic echocardiogram. She reports that she had undergone percutaneous closure of a septal defect months earlier. So which one of the following septal defects was closed in her? I specifically chose this because it raises another question that we may not have discovered, but an additional teaching point. So I'll show you apical 4-chamber view. Okay, and then I'll show you a subcostal view. Okay. So now this is just repeat the question. Which one of the following septal defects was closed? Primum ASD, secundum ASD, sinus venosus ASD, unroofed coronary sinus, or Gabordi defect? 20% chance to be right just by randomly, huh? It's okay. You always do eliminate, and then the increase is from 20 to 25 to 33%, 50, and then you're right. Okay? So, number 2, of course, that's secundum ASD defect, and essentially secundum, and the reason for that, that's the only form of atrial septal defect that it has a indication, on-label indication for percutaneous closure. That's amplice secundum ASD occluder, and just important for you to recognize that I can tell you a similar question, something like that, to asking you what device, and this is really this original because this is the central ASD unfast view in somebody with the right atrial perspective, just in the middle portion, and that's the only one that it's amenable to percutaneous closure under normal circumstances, or at least in the United States. We do devices for Gabor defect, but they are not approved. Okay, and one more question. So this is 77-year-old man with history of atrial fibrillation, intracranial bleed while on warfarin therapy, underwent closure of his left atrial appendage. Which of the following was the left atrial closure method in him? Okay, so this is dual view. Left, it's color, and then right, it's without the color. Okay, and then that's the 3D unfast view. And the questions are, so is that the lariat, is this a watchman, is this a surgical suture, is this atrial clip, or it's an amulet? I haven't shown an amulet, so now we have a 25% chance to be right, huh? Okay. And now my little GIF or GIF, huh? That's a big discussion, whether it's a GIF or GIF, isn't it? Okay. So, number 2, watchman, of course. I mean, I just wanted you to essentially recognize it's a relatively simple question, but I just want to make you sure. Can I just one more? This is just okay. So this is, the image represents a 3D view of the interatrial septum from the right atrial perspective. That's like one of canonical. Which number on the image corresponds to the location of the patent foraminal valley? Okay? So this is right atrial perspective of the septum, 1, 2, 3, 4, 5 in a counterclockwise. I'm just realizing there's going to be more and more, like nobody will know what's clockwise and counterclockwise. Huh? One's the analog. Huh? So this is 1, 2, 3, 4, 5. Okay. And my GIF or GIF is playing, and you are answering. You have to answer this correctly, huh? Okay. So it's number 5, of course. So that's number 5. And remember, that's it. The northeast corner. You came to Boston here. If this is American map, yeah, northeast corner. That's what PFO is. You will never forget that for all of the transeptal. I mean, you do transeptal, go away from the PFO. You go posterior rather than anterior. I hope you enjoy it, and we'll see you tomorrow.
Dr. Lang, are there any questions that you think we want to answer?
Yeah, please. Okay, so one will be maybe strange for you, but since we are friends, I can ask you. There are a lot of questions as from why is the Mayo Clinic format different from the rest of the country?
Well, listen,
and then there is, are we missing something? And probably we are, because the Mayo Clinic is the best hospital around, but maybe you can explain.
Well,
there are
of course, in the early
questions.
Yeah, the early days of transthoracic echocardiography, some of the legends in the field, like Dr. Feigenbaum, Dr. Tajik, Dr. Seward, basically wrote an article where they said you could either go with the Type A or Type B format. But the truth is, the Type A format, is the way the rest of the world scans, was chosen. But Dr. Tajik chose the Type B format. He felt that the heart sits in the chest with the ventricle down. That's the way the congenital format is. That's the way when we nowadays do TE at Mayo, we do image. And he felt that just simply rotating the heart so the apex was up was better than rotating the heart and then flipping it. But listen, it does make it complicated. I tried to flip a lot of the images, but sometimes the quality of the images are not the greatest, and then you lose your EKG, which is important when I do flip the image. I hope that the right to left part of it wasn't too tricky. We didn't show you any upside down TEs, at least.
Thank you. Let me ask you another question. Is there any way that you can help us differentiate coagulum in the pericardium from pericardial fat?
It can be difficult, but I think just the movement of the coagula, it has some independent movement to it, but it's tough sometimes. Now, this is in the setting of a post-MI. If you've had a transmural infarct, let's say you couldn't reperfuse and it's a transmural infarct, you can also get a pericardial effusion. And then if the patient has some fat there, it can be a tricky diagnosis. The points I would raise is the movement, the sinual movement of that coagula is really the best way to make the diagnosis, and the fact that it's new. And if the patient has chest pain or any instability, that's when you really want to look for that partial rupture that you might be able to get to the OR, or small rupture, contained rupture.
So very quickly, some words of wisdom regarding laminar left ventricular thrombus.
So post-MI LV thrombus does warrant maybe several months of anticoagulation. You can probably use a NOAC, or you can use warfarin. Discuss with your interventionalist if you can use a single antiplatelet agent along with a NOAC. Many of our interventionalists allow that nowadays, and the data is accumulating. Once 3 months go by, oftentimes that apical thrombus will become laminated. And when it becomes laminated, it turns out that the risk of an embolic event goes down dramatically. So it only gets a class 2B indication to continue warfarin beyond 3 months post-apical MI with a thrombus. But in that first 3 months, you definitely reduce the incidence of a CVA and embolic events. But if you think it's laminated and they've been on anticoagulation for a while, I'm a little bit squeamish about it, but the guidelines would support you stopping that Coumadin at that point. All right.
Okay, why don't you ask your questions?
All right, we'll go through these questions pretty quick. Most of them are review. So question 1, this post-MI image shows the presence of an LV pseudoaneurysm, LV aneurysm, myocardial rupture, or finding with a high risk of rupture. Great. Yeah, that's correct. And the key thing is here, of course, the wide neck. They're definitely going to ask you to separate pseudoaneurysm from an aneurysm. And look at the neck. That's really the key. This was an LV aneurysm that I showed during the lecture as well. So post-MI dynamic LV outflow tract obstruction is most commonly seen with an inferior MI, lateral MI, apical MI, or posterior MI. Post-MI dynamic LV outflow tract obstruction. Is that 100%? Oh, somebody spoiled it. Okay. Well, it is indeed the apical MI, because the basal segments become hyperkinetic, and that can lead to SAM and dynamic outflow obstruction. It's probably not as common as either post-MI VSD or a papillary muscle rupture, but it's not far behind. Okay, question 3. Which of the following is the most common cause of shock post-MI? Is it a VSD? Is it tamponade, MR secondary to papillary muscle rupture, or shock secondary to pump failure? All right, fantastic. Enough said. That, of course, comes from the shock trial right here. And I think we'll skip this. There is an incidence of thrombus, can be up to 10 to 15%, even with dual antiplatelet therapy, if there is significant LV dysfunction. All right? And we just talked about this, but just to summarize, the surgical mortality currently, in the current state of the art for a pap muscle rupture, is about 10%. If that's the case, which of the following is true? Survivors have a long-term mortality is higher in post-MI patients that didn't have a papillary muscle rupture, lower in patients that didn't have a papillary muscle rupture, or similar. Great. It's similar. So whether the mortality is 10 to 15%, you got to try it. And one last question, because this was on my echo boards, a very similar question a while ago, and it's frequently on general cardiology boards. This was a 63-year-old female that presents with the EKG below and a normal chest x-ray, and she suddenly develops hypoxia. What is the most likely cause? So first look at the EKG. See the inferior changes here. Pretty profound precordial and lateral ST depression. Here's RV4. Okay. Do you think this is a coexistent acute pulmonary embolus? Papillary muscle rupture with pulmonary edema? Right to left shunting through a PFO? Or methemoglobinemia? Now remember, in the stem of the question, I say that there's a normal chest x-ray. So that's really the key to knowing it. And all of these things can cause hypoxia. Methemoglobinemia can occur with IV nitroglycerin, but we don't use it that much anymore. You know, papillary muscle ruptures do occur, but you would have a lot of pulmonary edema if that was the case. This is actually a PFO. Remember, the incidence of a PFO is about 25 to 30%. And if you develop an RV infarct and you have a PFO, you could easily pop that PFO open and shunt. Let me show you this case. So this was a case of a patient that had a severe RV infarct. The RV is nearly akinetic. The LV is well preserved. The chest x-ray was normal, but the patient was hypoxic. And the reason they were hypoxic is shown here in this kind of an off-axis view of a cable view. But you can see there's tremendous shunting through this PFO from the right atrium into the left atrium, almost approaching that of mitral regurgitation, the velocity. In fact, we did a bubble study right here, and you can see there's a tremendous amount of shunting that's present. This patient had significant RV dysfunction, and we decided to at least transiently put them on RVAD support. We didn't close the PFO, we just put in a cannula here in the right atrium, and now you can see with the bubble study there's really no shunting. So these PFOs can pop open and close, and really it's a favorite board question. Think about it when there's hypoxia in a normal chest x-ray and something that caused acute cor pulmonale, whether it's an RV infarct or pulmonary embolism. So with that, I want to thank Dr. Lang and Dr. Riegelen from the bottom of my heart, and it was great to see all of you. Good luck on the boards, and hopefully we don't see you again next year.
Thank you, everybody, and we'll meet again tomorrow bright and early.